Now, here are a few things to take into consideration as we move forward. The labs, when discussing oxygenation, are going to be PaO2 and SaO2. Now, PaO2, this stands for the partial pressure of oxygen, while SaO2 stands for the saturation of oxygen. What's the difference? Well, PaO2, this reflects inhaled oxygen, while SaO2 reflects oxygen that is already within circulation that is bound to our hemoglobin. So when we're looking at how much oxygen is bound to a red blood cell, we are pretty much looking at how saturated is a red blood cell. So if we have a decreased PaO2, this means that there is going to be a decreased amount of oxygen that is being inhaled and distributed to our blood and tissues, which is going to equal a decreased SaO2 level as well. Now 60 is going to be the number that we're like, okay, it can't drop below this. But in the case where we're going into a decline in oxygenation, we do not want that O2 level dropping below 60 when it comes to the PaO2. Now, anything less than that 60, we're going to put them on a oxygen source. That's going to help increase the value, all right? Now, same thing goes for the SaO2. What we want here is a value between 95 and 100, but we want to keep it above 90. So we do not want that SaO2 level dropping below 90, guys. If the SaO2 level drops below 90, we're going to apply an oxygen source. Now, to make note of, which is going to be discussed a little bit more later in a separate video, is that of COPD patients. Now, COPD patients, it's okay if their SaO2 level is between 88 and 92%. Now, why, you may ask? Well, for the COPD patients, their stimulus to breathe is the lack of oxygen, which is called the hypoxic drive. Their body senses low oxygen, and that's what triggers their inhalation. Now, for individuals without COPD, we breathe due to the body sensing an increase in CO2. Okay, so it's the reverse. Our body senses carbon dioxide, and the body's like, let's blow this off, let's get it out. So due to the fact COPD patients breathe due to the lack of oxygen, if we give them too much oxygen, well, then they are not going to be triggered to breathe at all, because the body is like, we breathe due to the lack of oxygen. Therefore, if we give them too much oxygen, or there's an oxygen source that is giving them too much oxygen, we got what we need, there's nothing we're missing, therefore, we don't have to inhale or exhale. Therefore, they would go into an apneic episode for COPD patients. It would eliminate the hypoxic drive to breathe. So we're going to want to maintain low oxygen therapy for those COPD patients. Now, when discussing the next term here, which is V/Q, it just refers to ventilation and perfusion. V equals ventilation, Q equals oxygenation or perfusion. They go hand in hand. So there's a whole bunch that goes into this topic, but for now, just know oxygenation should always be more than ventilation. Now, the main topic of this video, the oxygen hierarchy, okay? When giving O2 to patients, we're going to want to follow these steps. So we're going to start from the lowest to the highest in terms of oxygen therapy. It's kind of like analgesics. When a patient comes in, we don't just put them on morphine or Dilaudid. There is stages. So we're going to start from Tylenol, oxycodone, and then morphine, for example. So here we are starting with low flow oxygen therapy and progressing. Now from low flow, there's high flow. Moving on to NPPV, which is non-invasive positive pressure ventilation, and then we're going to intubation, and lastly, mechanical ventilation, which is not going to be discussed that much in this video, morely in another video. Now, if a patient is unresponsive to any of these given oxygen therapies, meaning they are hypoxic as evidenced by a decrease in SaO2 or PaO2, that is when we are going to think about moving on to the next mode of oxygenation, which is going to serve, or hopefully serve, to provide a more concentrated set of oxygen for the patient, and that can maintain proper oxygen.